Good evening, everybody. This is the first edition of our Back to School webinar series at the University of Chicago Medicine Ear and Hearing. We have our members of our interdisciplinary team here tonight to discuss kind of their roles of what they do for the kiddos that we see that are deaf and hard of hearing, how we go about treating them, how we see them. Throughout this, we are represented by one of our neuro-otologists, Tedinbury. We have one of our speech language pathologists, Caitlin Egan, and one of our audiologists, Samantha Dixon. So we will go through this, and please save any questions that you may have for the very end. If you do happen to miss this, it will be posted on our YouTube page, which is UChicago Ear and Hearing. And with that, we're going to go ahead and get our first presenter going, which is Dr. Tedinbury.
Well, hello, everyone. I am Dr. Tedinbury. I am an otolaryngologist who specializes in caring for adults and children with ear and hearing issues. And sorry, I can't be in attendance with you live tonight. I've been with the program now for almost 3 full years, and I do really enjoy getting to work with the wonderful team of specialists that we have within our program from many disciplines. I'm originally from Virginia, and after I completed my otolaryngology residency, I did 2 additional years of fellowship training in the area of otology and neurotology, which entails ear and hearing disorders. So I'm really passionate about helping patients of all ages hear better, and my practice is just dedicated to that. There are a variety of medical and surgical interventions available to help people address their hearing loss. And, I get to do a lot of different things in that regard. Sometimes it's as simple as removing earwax or placing ear tubes to help drain fluid from an ear infection. And then I get to do, complex things such as removing tumors from the inner ear and junction of the brain to doing implantable hearing devices. And one of my true passions is cochlear implantation. And it's so rewarding to see a young child or adult be able to hear again after getting a cochlear implant. Our cochlear implant program has certainly grown remarkably in the past couple of years, and I really hope we can continue that trajectory in the future. So again, I wish I could be with you all live in attendance tonight, but I'm very happy to correspond in the future if anyone has questions or other discussion about any medical or surgical problems related to ear and hearing disorders. Dr. Severe, our program coordinator, can help facilitate that and share my contact information with you. Again, enjoy the night and hope you have a good time with the program.
All right. Now, going a little bit more depth in those medical and surgical interventions, we're again going to go back to Dr. Tedinbury.
Hello again. So I wanted to just kind of touch base and elaborate a little bit more about sort of my practice as an ear surgeon and sort of my philosophy for evaluating patients that I see. Again, I have a practice where I see both adult and pediatric patients, and I really try to, first and foremost, get a good history from the patient and our family members to just kind of help get a sense of what's going on. So we'll ask a lot of questions about, maybe the nature of the hearing loss, how long it's been present, any history of prior ear surgeries, trauma to the ear, infections. So there's a lot of details that we'll kind of go over when we sort of gather history and information on a new patient visit. And then important to those visits is a physical exam. And so, obviously we'll pay close attention to what's going on with the ear itself. Oftentimes that involves using a microscope to get a fine kind of detailed view of what's going on deep inside the ear. you can see one of the microscopes behind me that we have in the clinic here. So we have special exam chairs that allow me to recline the patient. And oftentimes, again, we'll be using a microscope or other instruments to kind of look into the ear. This is painless, just takes a few minutes, but gives me a good sense of what's going on with the ear. And I can then see problems such as, wax, infection, perforated eardrums, or other problems. One of the things that I enjoy as part of my practice and when I evaluate patients is that I get to work again collaboratively with a lot of other specialists in audiology and speech pathology. So many times during these visits, I'll have one of our audiologists get a hearing test on these patients to help kind of characterize for me the nature and degree of the hearing loss. And so, during your visit, you'll probably meet with me for the history and physical exam, get a hearing test and perhaps other diagnostics. There's some other specialized hearing testing and balance testing that we can do depending on the nature of the problem. And then we may also have you see a speech therapist, and speech evaluations are an integral part of helping us figure out more about the hearing loss and how maybe the hearing loss has been rehabilitated, especially in children. And so a lot of those appointments will oftentimes try to streamline for the same day or as the same day as a consultation initially. But again, oftentimes we'll get some of these tests the same day. So you'll have the results and I can go over them with you. And I oftentimes will use the results from the hearing test to kind of help guide further decision-making as to whether this is some problem that may be managed medically or perhaps better with surgery. As a surgeon, I love doing ear surgery, but there's a time and a place for it. So I'll always counsel you about medical options that are non-surgical. And then, if there are surgical options, kind of what's available, what are the risks and benefits. And again, it's not something I take lightly. Every time we operate on a patient, that's a significant undertaking, even if it does seem like something small and rather trivial. An example, just to kind of give you a sense of the spectrum of things that I take care of, from a surgical end would be, ear infections, treating something like an ear infection by putting in an ear tube to drain fluid. I see a lot of people who have had chronic ear infections and maybe have lingering kind of residual perforations or holes in the eardrum. And so there's usually associated hearing loss with that. And patients who have holes in their eardrum, they may not be able to swim or get water in their ears. And so being able to do surgery to patch the hole, to help kind of give patients more freedom with their ears and also improve their hearing. That's one of the bread and butter things that I do. I also enjoy doing a lot of implantable hearing devices, whether that's bone conduction devices for people that have conductive hearing losses or other unique hearing losses. And then there's also cochlear implantation, which is a passion of mine. Cochlear implants are implantable hearing devices that use electrical signals to stimulate the hearing nerve directly. And these, cochlear implants, I think, really, they are a great way to kind of highlight, how we all work together as a team, myself, audiology, speech and language pathology, to determine who's a candidate, who's appropriate for an implant, and then all the kind of aftercare in terms of programming and making sure the implant works appropriately, and speech, auditory verbal therapy to help make sure the patient gets the maximum benefit from it. But we're a very busy cochlear implant center on both the adult and pediatric side, something I'm very active with. And again, work closely with all the specialists in audiology and speech and language pathology to help guide decision-making for cochlear implantation. The majority of surgeries that I do are outpatient. So most of these patients will go home the same day with minimal downtime. But I also occasionally do more complicated ear surgery, sometimes in collaboration with neurosurgeons or other colleagues that do head and neck oncology or head and neck cancer. These could be, very large surgeries, removing tumors from the inner ear or associated area around the ear, even tumors that are deeper in the ear near the brainstem and other critical structures. So, the gamut of my surgical practice is very is quite varied, and that's one of the things that I enjoy. Simple things from ear tubes to very complicated procedures inside the skull base, using the ear as a corridor to access some of these challenging areas. And obviously, we kind of highlighted some of the surgical things I do. There's also a lot of medical things. So again, that's all part of the evaluation. There may be a medical option with antibiotics, cleaning, or other treatments that can be done in the office that don't require surgery. And again, every patient is unique and individual, and I'll always counsel them fully about the options. And again, it's oftentimes an important decision if you're making a decision regarding your ear and hearing. We kind of do that collaboratively. So again, that's sort of my philosophy. It's not pushy. I'm not going to tell you what's right, what's the thing to do. Again, we kind of work together to find the solution that is best for you, you and the family.
All right. Thank you, Dr. Imbery, for that. Once again, if you have any questions about anything, you can always put them in the chat, or we can talk about them in the end, and you will have our contact information as well as ways to send us messages through our YouTube page. So if you do have any questions or concerns, please direct those there. Moving forward, we're now going to move to the speech language pathology side. And for that, I'm going to turn it over to Ms. Caitlin Egan.
Hello, everyone. It's great to be here tonight. Just bear with me as I go ahead and pull up my screen here so everybody can see. Dr. Josh, if you can just give me a heads up, if you can.
Good to go.
Slides, wonderful. All right, well, thanks so much for having me tonight. It's great to be here. My name is Caitlin Egan. I am one of the speech language pathologists, or SLPs, for our pediatric ear and hearing team. Wanted to start off with some professional background about myself. First, I have no financial disclosures for tonight's presentation. And then as far as my professional background, I graduated with my master's degree in speech language pathology in 2014. And immediately after that, I began working pretty much exclusively with deaf and hard of hearing children. Prior to joining the team in 2019, I served as a school-based SLP for a self-contained deaf and hard of hearing program in the southwest suburbs of Chicago. Currently, I am working towards obtaining my listening and spoken language specialist, or LISL, certification as an auditory verbal therapist. I am happy to be one of 2 SLPs on our pediatric ear and hearing team. Pictured here is myself with my colleague Michelle, who is also mentoring me through the LISL certification process. So in regards to, before I jump into my roles and responsibilities on our team, I figured it would be great to just kind of briefly summarize some of the key best practice guidelines that we on our pediatric hearing loss team always kind of keep in the back of our heads. So certainly we know that best practice as far as supporting the deaf and hard of hearing child and their family is earlier is always better. The Early Hearing Detection and Intervention Organization, or EDI, has set out the 136 guidelines, and that's something that we take very, very seriously here at University of Chicago. And what I mean by 136 is all babies should be screened for hearing loss by 1 month of age. If that baby refers or fails one of those hearing screenings, we want them to have a full audiological evaluation to identify the hearing loss by 3 months. And by 6 months, we certainly want them enrolled in some sort of early intervention, set up with the appropriate hearing technology. And so that's something that we always are being mindful of here at University of Chicago. As far as the Annual Cochlear Implant Alliance, or ACIA, they do have a position statement on pediatric oral rehabilitation, or speech therapy, listening and spoken language therapy for deaf and hard of hearing children, specifically for children who end up receiving cochlear implants. Some of those guidelines in the position statement include an estimated 50 to 100 hours of speech and oral rehabilitation services per year for a child with cochlear implants. We want the provider who is providing those services to have additional training in the area of hearing loss. And any sort of provider, such as an SLP, who is engaging in oral rehabilitation services with a child, we want them to work closely and coordinate closely with the child's audiologist and the rest of the care team. So, what are my roles and responsibilities as an SLP for our hearing loss program? As a clinician, I'm going to conduct diagnostic speech and language evaluations on all of our pediatric patients. From there, I'm going to provide ongoing oral rehabilitation, speech and language therapy services. I participate in cochlear implant candidacy evaluations and discussions with the entire team as we're working a child and a family up for potentially receiving a cochlear implant. I collaborate with professionals both internally here at University of Chicago, but also externally with our community partners such as educators, early intervention providers. I provide counseling and education to family and caregivers of our patients. And we routinely monitor the outcomes of our pediatric patients utilizing hearing technologies such as hearing aids or cochlear implants. So when we think about a diagnostic speech and language evaluation, we need to remember that any degree of hearing loss has a potential adverse effect on a child's speech and language development and overall development. So any child that's identified with a hearing loss here at University of Chicago, it's our goal for any of those patients to receive at least an initial speech and language evaluation. And the purpose of that evaluation is to identify the child's current skill levels in a variety of communication domains. Some of those domains include speech articulation or clarity, receptive and expressive language, pragmatics, audition or listening, and many more. So when we conduct these speech and language evaluations, we want to take a whole child approach. That means that we're going to take in consideration, of course, the hearing loss that's been identified, but also whether the child has any comorbid or co-occurring conditions that may affect their communication. It's also important to gather information about the child's home life, the home language environment, through a thorough case history interview with the caregiver. We're going to utilize formal standardized measures that allow us to compare a child's performance to his or her same-aged hearing peers. We're also going to conduct informal measures such as caregiver questionnaires, language sampling to track subjective parameters over time. So after synthesizing all of the results of these formal, informal measures, and then also the caregiver interview, it allows me to generate appropriate and child and family specific recommendations for ongoing therapy, long and short-term goals, resources, and supports. In addition to the comprehensive speech and language evaluations that we complete, when a child is being evaluated for cochlear implant candidacy, we're going to take a even closer look at their functional listening skills to examine the benefit of the current hearing technology that the child is using. And these types of functional listening measures will assist us in answering a critical question. Does the child's hearing technology give them the auditory access needed to develop speech and language skills commensurate with their same-aged hearing peers? In addition to completing these functional listening assessments, we also need to critically evaluate the whole child to identify any other factors that make the child a strong candidate for cochlear implantation, or on the flip side, factors that may adversely affect the outcomes of the cochlear implant. Some of these factors that we need to consider are duration since onset of hearing loss, consistency of the current hearing technology device use, and the type of family support, amongst many others. All right, so completing that initial evaluation allows me to generate those long and short-term goals for the patient and their family. These goals reflect the needs of the child as well as the goals of the family in regards to what type of communication approach they want to adopt and commit to for their child. So after that initial evaluation and we synthesize the results, we're going to create a treatment plan to target those long and short-term goals. So that's your ongoing oral rehabilitation, speech and language therapy services. These services are going to be child and family specific. No treatment plan looks the same. No session looks the same because every family and every child is different, of course. The silver lining of the COVID-19 pandemic is it really has boosted up our opportunities for remote therapy services. So while we do offer in-person therapy services, we now offer telehealth services as well. Our treatment planning is going to, like I said, address long and short-term goals in many different areas of communication. Some include, the most frequently targeted domains of communication include audition or listening skill development, spoken language, articulation or speech clarity, and then self-advocacy skills. Another huge part of a speech and language therapy session or oral rehabilitation session is going to be the parent coaching piece. So really, any child between the ages of birth and 3, we are really going to adopt that parent coaching approach. And that means we're going to provide the parent or caregiver with the necessary tools in their toolbox to develop their child's listening and spoken language skills at home, while they're out at the grocery store, et cetera, et cetera. It's also very important to collaborate with the child's educational team or early intervention providers to ensure that the patient needs are being met and the family goals for their child are at the center of care. So in addition to the initial evaluation and annual reevaluation, as well as our ongoing therapy services, as I mentioned before, I also conduct quarterly outcome monitoring check-ins to closely track the child's progress in listening skill development. This allows me to identify the child's trajectory and identify any barriers to them making the progress that we would expect from them after initial activation of that cochlear implant or the fitting date of the hearing aids. So certainly we're going to use those formal assessment measures that I mentioned in the evaluation slide, but then we're also going to use some measures specific to the deaf and hard of hearing population, such as parent questionnaires that kind of track functional listening and auditory skill development. And then we also can use additional monitoring tools, such as questionnaires that go home to the classroom teacher, maybe get their perceptions on how they feel the child is listening in the classroom, which may be a little bit more of an adverse listening environment. And then certainly our monitoring schedule, in addition to our annual evaluations, we're going to conduct these outcome monitoring check-ins every 3 months. So family and caregiver education is one of the most, if not most important parts of my job. I see a child typically for 60 minutes a week, which accounts for less than 1% of their entire week. That's why empowering the parents to be the team captain for their child's speech and language development is so important. So here are some of the key topics I routinely provide counseling and education on. And this is really an ongoing conversation, not something that's brought up once and kind of never brought up back again. It's topics that we're always kind of checking in on to make sure that the family is understanding everything and they feel supported. So certainly we want our families to understand the effects of hearing loss on speech and language development and any other area of development. Again, we want to give the family space and an opportunity to develop goals for their child in relation to what type of communication approach they want. And even we can think about more holistically what goals they have for their child. Where do they see their child in 5 years? Where do they see their child in 10 years? It's really important to create a safe space so that the family can brainstorm these types of things, because that's truly going to be at the center of all of our treatment sessions and goals. Like I mentioned before, parent coaching, we're going to provide the parent with the resources and strategies to make every day and every daily routine a learning opportunity for their child. As far as our cochlear implant candidates, so a child and family that is looking to get a cochlear implant in the future, it's really important for me to provide education on the importance of post-operative follow-up care. Many times families come in and think that receiving the cochlear implant and having it turned on is kind of the last step in the journey, and really it should be viewed as the first, because what predicts positive cochlear implant outcomes or listening and spoken language outcomes is attending frequent specialized oral rehabilitation services, wearing the cochlear implant full time, 8 to 10 hours, and then following up with audiology and their ENT consistently. And that's a really important piece for families to know before they start that journey. In relation to kind of the factors that make someone an optimal candidate for cochlear implant and maybe things that may make them less of a candidate, we want to make sure that our families have realistic expectations of the listening spoken language outcomes for their child with cochlear implants. You know, a lot of times we need to kind of scale back our expectations of when they're going to say their first word, when they're going to be able to listen and understand and follow a conversation. It's unfortunately not like a light switch, as many families come in thinking, and we can really do a lot of counseling on that timeline for them. As I stated before, there is a wide spectrum of communication approaches that a family can explore and choose for their child. As an SLP, my role in exploring communication goals for their child is threefold. I'm going to support the family in making decisions related to their child's communication by providing them with comprehensive information about all of their options, connecting the family to professionals that specialize in whatever approach they decide on, and empowering the parents to take necessary steps to ensure access to language. So, you know, many of our families want a listening and spoken language approach for their child. So we're definitely going to focus on, you know, engaging in frequent oral rehabilitation services, finding early intervention providers in the community that also specialize in listening and spoken language, and eventually connecting them to an appropriate educational placement that reflects the goals of the family. Additionally, if we have a family that's looking for a total communication approach, meaning they want visual communication such as American Sign Language as well as spoken language, we're going to want to connect them to the professionals that are proficient in not only spoken language, but also American Sign Language. One of the best parts of my job is that I get to work with all these people here that you see in the picture. Some are missing, but collaborating both with our colleagues here at University of Chicago and then externally with our community partners is one of the best parts of my job. So ongoing communication with the child's audiologist is absolutely essential for patient and family success. I learn so much from our pediatric audiologists every single day, every week, and I'm sure they're ready to like lock their door because I'm constantly knocking on the door, asking them for you know, questions, getting their advice. So it's absolutely crucial to have those open lines of communication. One of the biggest goals for a very young child or baby that just receives a cochlear implant is really increasing or establishing full-time use of the hearing aid or the cochlear implant. It's essential for me to work alongside audiology so we can track the data logging, meaning the average amount of hours per day that the child is wearing the device. That provides a nice objective metric for the family to track as well. And then also just tips and tricks for device retention. I feel like I'm always kind of picking audiology's brain about that, so we can really support the family as they work towards establishing that completely essential full-time use of the device. On the flip side, I'm able to provide thorough analysis of the child's sound detection and identification skills, as well as their speech production skills can sometimes be a tip-off as far as what type of auditory access do they currently have with their device. If I'm noticing a pattern of, certain sounds that they may not be responding to, or certain sounds that they're not saying themselves in their own spoken language, that may be an indication that there's some audiological programming or manipulation to the cochlear implant programming that may be a benefit to the child, and we work together closely with the audiologist to see that happens for the best map possible for our cochlear implant recipient. We certainly work together to provide comprehensive cochlear implant candidacy evaluations. It's not a one-person decision. It's a whole team, and that includes the family as well. And then finally, we're always consulting with our ENT providers. So if there's any medical concerns for somebody that I'm seeing routinely, certainly I'm going to refer to our ENT providers. Finally, collaboration with our community partners like educational teams, the educational speech path that sees my kid who I see in clinic. It's important for us to be have those open lines of communication, so I'm aware of what their focus is on in the schools, and they're aware of what our goals are here at clinic for my treatment planning. Educational audiologists, classroom teachers, and case managers. It's really important for us to keep those lines of communication open so we know that the child and family's goals are being met. Also communicate very frequently with early intervention providers. They have the glory of being able to go directly into the home and really experience the home language environment of the child and the family. And that can be really, really helpful for us as clinical providers to know what exactly is the home language environment like. How much stimulation, how much language is the child hearing every day? That can really help me out as I'm providing services when they come into the clinic. We also provide outreach opportunities such as in services to daycare, about working with a child with hearing loss, making it a hearing loss friendly environment, and then certainly partnering with hearing loss organizations to really provide community outreach as much as possible. So this is really a very brief kind of blitz overview of the main primary roles, responsibility and roles that I have on our hearing loss team here, but I'm happy to answer any questions or connect over email. I have my email here, and I really appreciate the hearing loss team here letting me come and talk about the job that I love so much. So Dr. Severe, I will turn it back over to you. Thank you.
Thank you. That was awesome. Really appreciate that. Once again, if you have any questions or anything, you can always throw them in the chat, or you can send us a message afterwards, and we'll move right along to the audiology portion of tonight's Back to School webinar. And for that, we're going to move to Dr. Samantha Dixon.
All right, good evening, everyone. My name is Samantha Dixon, and I am a pediatric audiologist. I've been practicing audiology for 7 years, and I have been with this program for over 2 years. Here at UCM, I am the newborn hearing program coordinator as well, which involves monitoring our newborns at the hospital, making sure that they receive their hearing screenings, making sure they receive additional testing if they have risk factors for hearing loss, and also making sure that those babies are following up with audiology or other specialists where appropriate. Sort of as Caitlin mentioned, making sure basically we're following those the 1-3-6 month national recommendation model for the diagnosis and intervention. I'm also the audiology representative for the craniofacial clinic, which coordinates with the plastic surgery department for craniofacial anomalies such as cleft palate. My primary responsibility as a pediatric audiologist at UCM is diagnostic hearing testing, diagnosing hearing loss, recommending and implementing best treatment options while working closely on a multidisciplinary team for each patient to ensure they're receiving the most appropriate and effective care. My interests with this job include the diagnostic procedures and the process of intervention and rehabilitation. I absolutely love working with kiddos with hearing loss as well as their families, and it's an absolute joy watching the child and the family grow in that process. So let me just pull up my PowerPoint. Ooh. Okay. All right. Cool. So today I'm going to be going over the pediatric audiology and our overall process from referral to evaluation to diagnosis to treatment. So when we're looking at just this little outline here, so the things I'm going to cover are the most common reasons for referrals to audiology. When we're talking about evaluation of hearing, the actual methods of testing hearing, diagnosis of hearing loss, now what are the next steps, and then intervention for hearing loss and reviewing the different device options. So with referrals, one of the biggest ones is not passing the newborn hearing screening at birth. Per our national recommendations, I know Caitlin touched on this a little bit, our initial newborn hearing screening should be performed prior to 1 month of age. A diagnostic test should be completed by 3 months of age. If hearing loss is diagnosed, intervention should be implemented by 6 months of age. However, the nation is rapidly moving towards a goal of screening by 1 month, diagnosis by 2 months, and intervention by 3 months. Basically, the earlier hearing loss can be diagnosed and intervention can be implemented, the better, especially if spoken language is the family's desired method of communication rather than something like sign language. Then early intervention with hearing aid devices is recommended to provide adequate access to sound for speech and language development. One of the other big referrals to our department would be risk factors for hearing loss. So certain risk factors require follow-up to audiology despite passing the newborn hearing screening at birth. Some of the more significant risk factors for hearing loss include congenital cytomegalovirus, or CMV, which is a viral infection passed from mother to baby, meningitis, specifically bacterial, ECMO therapy, which is extracorporeal membrane oxygenation, which is for cardiac and respiratory support in those infants, head trauma, and especially family history of hearing loss. Some additional risk factors would include ototoxic medications, meaning medications that are toxic to the ear, such as chemotherapeutic agents, several days of antibiotics, and other things would be craniofacial malformations, such as like cleft palate or microtia atresia, where the ear is actually closed off. And then, of course, there's quite a variation of syndromes where hearing loss is associated with those. The other big referral is delays in speech and language development. So if a child is not meeting those speech and developmental milestones, usually the child is first referred to audiology to rule out a hearing loss. That's usually, that's a big age range between like 12, 14 months up to like 3 or 4 years of age is where we get those referrals. The other big one is not passing school or a school or a pediatrician hearing screening. So hearing screenings are often performed in grade school, as well as the pediatrician's office. When a child does not meet the passing criteria, they're then referred to us. And then, of course, parental concern, caregiver concern, teacher concern. So if the child doesn't seem to be responding to sound, such as they're not responding to their name when called, they're not answering questions, people find like they have to repeat themselves, the child can't seem to follow basic commands, maybe they don't startle to loud sounds. From the teacher's perspective, a lot of those same things, but maybe they're noticing issues with the child's attention to tasks, or just looking at poor academic performance overall. All right, and moving forward, just to go over some different ways that we do actually evaluate hearing. So we're looking at auditory Evoke potentials, which is a more objective measure of determining hearing thresholds. You also hear it described as auditory brainstem response, or ABR. This is something that we perform up to 6 months developmental age or younger, typically under natural sleep, or when behavioral testing cannot be performed either under natural sleep if a patient can nap easily, or under sedation. This can be performed on older children who are not able to be tested behaviorally, such as when there are developmental delays present. There's a lot of patient distress where the patient's just too upset to tolerate the task, etc. This is our primary evaluation when a baby is referred on the newborn hearing screening. And so what this does is measures auditory nerve responses to sound, which is an electrophysiological measurement, measuring the activity of the auditory nerve up to the level of the brainstem via electrodes. And we're using different sounds of various low to high frequencies or pitches that are presented into the ear through an earphone, and the response of the nerve is measured through those electrodes. And hearing thresholds can therefore be determined based on the softest intensity levels where a response from the nerve is measured. So now I'm going to go provide an overview of behavioral hearing evaluations, or what we call audiometry. There are a variation of test methods based on the patient's age and their capability to participate in the task. And these tests are performed in a sound-treated booth. You can also expect to see these types of evaluations several times over a child's life when a hearing loss has been diagnosed, not just for repeat testing for monitoring purposes, but to also assess the functional benefit of their hearing devices. So starting with our first one is behavioral observation audiometry, which can be used for developmental age birth to 6 months. We're looking for responses from the child that include eye shifts, changes in breathing, changes in sucking if they're nursing or sucking on a pacifier, quieting if they're in the middle of making noise or crying, or we're also looking for startle responses. This is also used for multiply involved or difficult to test patients. It may not estimate true thresholds, but can give us an idea on where patient responds to sound. This is a very, very subjective interpretation, so it does need to be interpreted with caution. So it's important to cross-check with any other sort of objective measures or physiological tests like the AVR, as we mentioned before. And the next test up in age is typically for our 6 months to 2.5 years developing age, which is called visual reinforcement audiometry. Sounds are presented to each ear through headphones, and the child is conditioned to turn their head towards an animated toy or video screen, which acts as a positive reinforcement to turning their head in response to hearing the sound. As we continue to present sounds to their ears, and the child is turning their head, indicating a hearing response to that sound, and we're able to document that. And conditioned play audiometry, that's usually for 2.5 to 5 years of age developing. A patient is conditioned to play a game by dropping a toy in a bucket or placing a peg on a board in response to hearing the sound through those headphones. The nice thing about this, it keeps the test fun and interesting for the child and helps us to get a more complete test too, if we're worried about losing that interest, or what we call fatiguing, tiring out, boredom. And as for traditional audiometry, this is going to be our 5+ years typically developing child. Same thing with sounds being presented through the headphones. This time when the child hears those sounds, they're either raising their hand, they're saying yes when they hear the sound, pressing a button, that sort of thing. Any of these behavioral tests that we just went over can be used depending on the child. If they're bored, if they're developmentally delayed, we're just kind of handling we're going to use the test that's going to work best for that child in the moment. And sometimes a combination of the above are used. So now if we're looking at a diagnosis of hearing loss, I'm not going to go into the different types of hearing loss, but for the purposes of this discussion, we'll be talking about the process related to a diagnosis of a permanent type of hearing loss, resulting in a recommendation of a device. So a hearing loss is diagnosed, what's next? So we are going to submit referrals so the Illinois Early Hearing Detection Intervention EDI program coordinators, which are early intervention, that's designed for birth to 3. The early intervention ensures that patients with diagnosed disabilities or developmental delays receive appropriate resources and services. This is no charge to the family, these services. There's UIC also has a division of specialized care for children, or DSCC. This is actually birth to 21 years. So they assist with arranging and coordinating for a child's medical treatment, including financial assistance for eligible medical conditions, and also if meeting certain financial criteria. The other big referral would be our ear, nose, and throat, or ENT specialist, such as Dr. Imbery. That's to establish care for continued monitoring of the hearing loss. On top of that, the ENT will likely refer to other specialists, such as a geneticist. They might recommend imaging at some point, which would be an MRI and or a CT scan. To evaluate the anatomy of the ear. And then usually a referral to speech is often immediate, as the speech and language development goes hand in hand with hearing, as Caitlin was talking a lot about. EI often offers speech therapy for birth to 3, and we of course have our incredible auditory verbal therapists here at UCM. Illinois Guide by Your Side program is a great program that's also free to families. They provide family support, so it involves a parent guide who has a child with hearing loss, who then provides one-on-one support to those families who also have a child with hearing loss. So these referrals are automatically going to these programs, so that then they reach out to the families and offer those services. And then finally, the next important option is the consultation with the pediatric audiologist to discuss those hearing aid device options. So just to kind of give a quick review of those device options, the first one, hearing aids, usually first and most common technology recommendation for a permanent type of hearing loss. So how do they work? They work by picking up sound through a microphone and provide amplification using digital programming based on the degree of the patient's hearing loss, therefore allowing appropriate detection of sound in the environment. The features, one of the things I always like to mention when diagnosing a hearing loss are those custom ear molds. The reason I like to bring this up right away is it requires regular replacement due to growing ears, especially from infant to toddler age. So I always say be prepared to see me on a regular basis simply to just update the custom ear mold fitting. They do come with the hearing aids come with tamper-proof battery doors, which is typical for 3 years and younger, prevents children from opening the battery door and getting into the battery, as zinc air disposable button batteries are poisonous if swallowed. They also now have rechargeable options, and especially now in even sleeker options than we did before, with improvements in the length of the full charge up to 16 to 21 hours per day. It's definitely an added convenience for parents. You're not have to fiddling around with changing a battery or worrying about if you have batteries on hand. It's also great for school age children because it allows the child to more easily take responsibility of the devices and care for the devices on their own. LED lights are standard. So that's just a light on the hearing aids that tells you what's going on with the hearing aid, whether it's on, whether the battery is low, etc. The other big thing that's, becoming more and more popular are the wireless and Bluetooth capabilities. So the hearing aids pair to iPhones, they pair to some Android phones. So you can use apps to monitor battery life, volume control. There's a Find My Hearing Aid function. So it'll GPS the last location the hearing aid was in before the battery died. We know loss is big with kids. Kids will, take the hearing aids off, throw them somewhere. It's just going to happen. So those are some nice safeguards. For our older kiddos, Bluetooth connectivity allows for streaming of audio, such as phone calls, music, virtual learning from phones, tablets, and computers. So other great options there as well. I think cost coverage is an important thing to note. I know that's a big concern with parents and caregivers. Typically, costs for hearing aids that can range anywhere from $800 to $5,500. That does include a 5-year warranty on those. But more and more insurance companies are offering partial to almost full coverage for hearing aid devices, especially for our pediatric patients. State programs such as early intervention and DSCC can also provide coverage if we can obtain approved authorization from these programs. We also have a loaner program at UCM where we can fit devices on loan to avoid delaying a child's access to sound. And this is that during that time period while we're navigating, trying to figure out how the payment can be covered, or while we're waiting for state program authorization approvals to come through, which sometimes can take many, many, many months. Also, for severe to profound hearing losses where cochlear implantation is likely the primary recommendation, the loaner program is a great option for the hearing aid trial before cochlear implantation. And so speaking of cochlear implants, I'm not going to go into too much detail. This is a whole nother world on its own. But just kind of how do they work? This is an implantable surgical device. This is for children where a hearing aid is providing limited benefit at this point, especially in severe to profound cases. A cochlear implant picks up sound via microphone on an external sound processor device worn on the ear and the head, with the sound sent to the internal device where the auditory nerve is directly stimulated via an electrode array. Programming is also specific to each individual patient. With their features, a lot of them are the same as hearing aids. One of the things that's nice about this, they have different types of sound processors and accessories to allow the choice of the sound processor to be worn on or off the ear, depending what's best for each individual child and the family. Every kiddo is different. We just want to try and make the maintenance as less as possible. They also have rechargeable batteries. They have those LED light indicators like hearing aids, also offer the Bluetooth connectivity options. One of the benefits with this is that usually getting a cochlear implant comes with accessories, so you can get some additional helpful devices to use, such as waterproof casing options for the sound processors. Hearing aids are splash proof, not waterproof. So this is a little extra benefit with the cochlear implant. And then also accessories such as FM systems or remote microphones, which we'll discuss here in a minute. When it comes to costs, these devices are usually covered by insurance along with the surgery. The other device I wanted to mention was the Osteointegrated Devices, which means bone conduction hearing aids. So how do these work? They're designed for more permanent type conductive hearing losses, such as microtia atresia, which is what I mentioned before with the craniofacial clinic team. This is when the ear canal is completely closed off, but the inner ear and the hearing nerve are healthy and normal. So it's just a matter of getting the sound to that normal hearing nerve. The sound processor lays against the head and the microphone picks up the sound and sends the sound vibrations through the skull bone directly to the normal hearing inner ear. The device can sit on the head with a headband as seen in the photo, and it can also be implanted using a magnet or a metal screw. I'm not going to go into all these details. This is a little bit more of a rare option in comparison to hearing aids and cochlear implants. You just have to be a very particular kind of candidate for this device. It's a great option for those that it applies. This is why I want to mention it, but it is a little more rare. Their features are very similar to the other devices. They have those tamper-proof battery door options for the younger ones. They have the LED lights, similar Bluetooth connectivity options. With the cost, it is more similar to hearing aids. There might be an out-of-pocket cost, but it's that same options with potential insurance coverage, as well as possibly through the state programs. The other thing when we consider, the classroom and school, FM systems and remote microphones do work with all these hearing aid devices in some way, shape, or form. The hearing aids, the cochlear implants, and the osteointegrated devices, some might require sort of more parts than others, but the setup can be done. This is something that can be purchased through our facility or anywhere. It could be an option to pick as an accessory with when you get a cochlear implant. It could possibly be covered through insurance. It could also be provided by the schools as well. I describe its function as this extra hearing bonus, especially in situation with background noise or where there might be more distance between the speaker and the listener, especially in a classroom. So the way that functions is that, for example, in a classroom, the teacher would wear the microphone and the transmitting device. The device that's worn, worn like on a lanyard around their neck or clipped to their shirt, and then the microphone picks up the teacher's voice and streams their voice signal directly to the hearing aids. This device can even be helpful for kiddos without a hearing loss who maybe just struggle with some processing issues or difficulty hearing in background noise. And it just gives you, again, that little extra boost to just make things a little bit easier in the classroom. I'm kind of rounding things up. So for takeaways, our goals are to ensure, accurate hearing loss diagnoses as early as possible. One thing to note is that mild hearing losses and unilateral hearing losses can very easily be missed throughout childhood. There's no harm in performing a hearing evaluation. If there are any concerns, even if minimal, we're happy to perform a hearing test. That's no problem. We'd rather know than not. It's important to recognize that the diagnosis of a hearing loss often results in a long process requiring hearing loss monitoring, device management, et cetera. We are here at this program to make this process as easy and effective for each individual family. One of the things it's really important to me, and I think also to families, I make myself very easily accessible to each family. They're encouraged to reach out to me directly via email or phone if any questions are concerned, and I want them to be able to reach me right away so I can get back to them as soon as possible and make sure everything's okay with each individual child. Our group works as a team, audiologists, speech therapists, ENT, social work, et cetera, to ensure our patients are receiving all services they need and receiving maximum benefit with their treatment method. For example, the speech therapist will let me know if there's patterns and auditory discrimination errors through their regular sessions with the child, and then I can use this information to adjust programming of those devices. So we really work and communicate together to make sure that we're not missing anything, that we are on the same page, and that we're using that information to actually make adjustments and make things better for the child. We also work as closely as possible with the school of each individual patient to make sure everyone is on the same page with treatment. So if concerns are coming up at school from the teachers regarding functioning or effectiveness of their devices, and to assist in obtaining additional equipment, for example, such as FM systems, that's what we're here for. The schools also sometimes have educational audiologists that can perform these behavioral hearing tests that I went over earlier, and also can aid in some hearing aid repairs there at the school and in the classroom. So the goal, my goal and our program's goal is best patient care with the most beneficial hearing outcomes tailored to each patient's individual needs. And that is all I have. Thank you.
Thank you. All right. Well, this has been a very nice overview of kind of what we go through when we're diagnosing and treating hearing loss for our kiddos. I hope this was informational. If you have any questions, concerns, anything, you can definitely reach out to us by email from the specific providers or any of our social media platforms, which they're all UChicago Hearing for every single one of them, Instagram, YouTube, Twitter, Facebook, everything. So if you ever need to get in touch with us, we're always easily accessible, and we look forward to working with you any way we possibly can. I want to thank our guest speakers from our interdisciplinary team tonight for taking time out of their night to present on this. And I hope it was, like I said, informational for everybody, and we'll see you soon for the next one.